So again, we'd like to thank all of the panelists here for being here today, talking through a lot of great items. We have Leslie is going to be on the back on this side, and we have Sabrina is going to be on this side over here with the microphones. So besides some just random questions and discussions and questions amongst yourselves as well, we'd like to get some feedback from the audience. So I'll start it off. So, you know, as we were hearing a lot about the different progress going on, not only within general diagnosis, management of PBC, and obviously some of the innovative treatments, and obviously managing transplant when you're expecting a transplant. As we look towards, you know, one of our goals is we're looking towards the cure, right? So thoughts amongst yourself, maybe start with Dr. Gershwin and kind of work down the way. What do you think are the most hopeful options as far, or best pathways to that cure? Not to put you on the spot, but.
Not to put me on the spot. I still hold a lot of faith in the nanotechnology approach, which has already been shown to be successful in gluten enteropathy, where you take the autoantigen, you put it on a liposome, you give it to a patient with disease, and it induces immune tolerance. And I do know there are trials that are ongoing. I think that there's even some of you in this room maybe that have been involved in at least one trial. There's a couple more companies that are going to begin trials. And if it doesn't work, then it means we've made a lot of mistakes. Okay, it may not work completely, it may not work in everybody, but to me, that is the most innovative approach that I know about.
Okay, Dr. Vierling, thoughts?
Well, you know, without being specific as to what the technology is going to be, I think that the concept of reestablishing tolerance is the wave of the future for a cure. And I think that the basic science is being translated in manners, and Eric just shared one that's already in trial, that suggests that we may achieve that. Now, that's not just for this disease. That would impact autoimmune diseases in general. It could impact allograft survival without the need for immunosuppression in solid organ transplants. It has broad applicability. And I think that it is still something we haven't achieved, but I think it's on the horizon. Mm-hmm. If you couldn't achieve that, and Eric said, well, if it doesn't work, then maybe we've made a lot of mistakes in our thinking and how we've interpreted things. I think the second approach would be one that we're not capable of making right now, because Eric pointed out, this disease, when it starts, is without symptoms, it's without any changes in your biochemistry, and it is undoubtedly active in the liver lesions. This destruction of bile ducts, inflammatory destruction, is going on for years before that alkaline phosphatase rises into the abnormal range, and you would even be subject to a diagnostic evaluation under our current clinical diagnostic criteria. So what do you do to try to find those people earlier? And this hasn't come from genetics. Eric shared that. It may still come in some manner where we get ahead of an identification early on of a group at risk. When it's a rare disease, having still the rarity in our favor to potentially monitor. And the first known issue has been this development of antimitochondrial antibody. Whether it actually is the only and the most common thing, but if it's the only thing, I don't know if that's going to be true or false, but that would allow you to potentially do something about the destruction. This duct destruction, I got up and shared with you the destruction, and then I said, well, it causes, as a consequence, cholestasis. And everything I told you about therapy is directed to the cholestatic consequence of the ongoing destruction, which we're doing nothing about. So I think getting a hold of the ability to stop that destruction, if you did it early enough, it would stop the development of cholestasis and stop the need for anti-cholestatic therapy.
Great. Dr. Carey, any thoughts?
Well, these two gentlemen have very intelligently elucidated the important points, but I agree I think we're catching this way, way, way too late. And having more information to figure out, as Dr. Vierling said, who's at risk and what exposures are potentially triggering the response that leads to PBC. But I think we're intervening too late in the process right now.
Agreed. Okay. Leslie, any questions from your group?
If your liver enzymes are in the normal range, your FibroScan is also in the normal range, is it safe to assume that your liver is stable, or can there still be progression of PBC?
Dr. Vierling, you want to take this one?
Everything that we know could be translated back into some of the data I shared with you, and that would be that the alkaline phosphatase is truly deep in the normal range, that the total bilirubin is like 0.6 milligrams per deciliter. If you have that, and then you have a FibroScan, which is essentially saying there's no evidence of stiffness, that the liver is like one you could buy in the market, kind of spongy and soft, and not at all fibrotic and giving that stiffness signal, then you have fulfilled all of the absolute best criteria we currently know to say that you have a non-progressive, fully treated liver disease.
Interesting. I had a question too to follow up from your discussion earlier on the IL-31 around itching. What's the timeline as far as using that as a diagnostic or a prognostic aspect around itching and managing it?
Well, you know, in terms of discussing IL-31, it's such a simple question. I'm going to let my chauffeur to the right actually answer that, because
Nice.
Eric is much more informed on the status of IL-31 as a biomarker for itch.
Cool.
So there have been a whole variety of biomarkers proposed over the years. Autotaxin, for example, amongst others. I tend to think of, are they going to work in terms of if you inhibit it. Itching is a very complex process. Itching from a mosquito bite is very different from itching from a variety of other reasons. And the other thing, and maybe you two should answer that, I have the impression that itching is not as big a problem as it was 25 years ago. That itching was more common in the past than it is now. I mean, certainly we know people are doing better than they were 25 years ago. We know URSA doesn't help someone who itches. The question is whether or not, if someone started URSA at the very beginning of the disease, is that going to put them in a population at lower risk of itching? What I'd say about IL-31 is that I'm not optimistic, but I'm not beyond belief.
Okay.
Okay.
Okay. Good to know. And Sabrina, I think you had an interesting question too on kind of like looking at cells, right? So,
I've recently been reading a book on the HeLa cells. Have they been tried with anything with PBC to see if they're effective? Do they make it worse, or not been tried at all?
HeLa cells?
HeLa cells.
H-E-L-A?
Yeah.
Yep.
So this is the cell line
yeah.
that was derived from a cervical carcinoma.
Yep.
Of Harriet Lane, and hence the HeLa kind of name that was given to it. This is a highly transformed malignant cell of human origin, and it's been used in a variety of studies. Actually, it has been studied as a target cell for natural killer cell activity in patients with PBC. Keith Lindor and I independently did those studies way back when. So the answer is yes, but when you're thinking about them as a therapy, that's something that doesn't make much sense to me in terms of how we're envisioning it being therapeutic. It is a malignant cell line.
Okay, cool. And Dr. Carey, I had a question for you. You mentioned and kind of showed the visual of the liver pump for transplantation. That seems kind of exciting as far as, ensuring the stability and giving that longevity as far as getting ready. Is that something that is approved in the process? What's the timeline as far as that being, helping access?
It's FDA approved, it's available, it's very expensive.
Yeah, of course. Okay.
And so that's the limiting factor, is most programs would go bankrupt if they used it as much as they wanted to. So most programs are really struggling to figure out which patients they can use the pump to kind of, get the most bang for the buck, so to speak.
Interesting.
Yeah.
Okay.
Yeah.
Okay. Leslie, any questions? Other questions to?
Yes. Is there any indication of a correlation or environmental factor that could be associated with menopause or perimenopause that would explain why perhaps females get PBC more often than males?
You know, we have 23,000 human genes. Do you know that 50% of all human genes have estrogen response elements? Which means estrogen, I don't, pardon the word of the used promiscuous, estrogen is amongst the most of the promiscuous molecules in any animal species. So there's no shortage of possibilities of why women get more PBC. There is a very interesting body of research by a guy named Howard Chang at Stanford, who's studying something called XIST, ZIST, in which he can look at structural elements on the X chromosome that he believes explain why autoimmunity is associated with the X chromosome and with women. So I think you can hear a lot more about that in the future. A lot of people think it's really, really hot.
Interesting. Let's see. Leslie, do you have any others? Or Sabrina, I think you just picked up one.
Yep, I have two here.
Okay.
What made you decide to study? I'm not sure what that word is. Disease and PBC specifically.
Oh, AIH or?
I'm not sure.
Does anybody who wrote the question want to clarify?
Oh, liver disease and PBC specifically.
Eric, why don't you lead off? We'll go on
Yeah.
the horn.
You want me to go first?
What made you go into
Well,
this?
okay, so I'm almost 40 years old, once upon a time, and it's 1986, and I was studying lupus and mouse immunology, and I suddenly had this feeling I didn't want to study lupus and mice with lupus for the rest of my life, and I went on sabbatical to Australia, to a place called the Hall Institute, and I went for 6 months, although I ended up staying a year and a half, and I was studying actually a different disease in the liver, nothing to do with PBC, a molecule called F-alloantigen. But the bottom line was this. I went to work with a guy named Ian Mackay, who really deserves the credit as being the godfather of liver immunology. And Ian was away on a long weekend, and he asked me to cover his medical service. I actually have I believe it's still active, an active Australian medical license, believe it or not. So if you're in Australia, you need to see a doctor, and I'm there. I might be the guy.
Nice.
But in any case, he was away, and one of his patients with PBC was in the hospital, and the med tech couldn't collect her blood because she didn't have any veins. Well, when I was a med student, I worked on East 1A, John knows it, as a venipuncturist to make money in medical school. And in those days, I could get blood from anybody. And so I went down there, and I collected her blood. And it turned out she had liver disease, she had PBC, and I was studying another liver disease in mice, and cloning had just started, and I was going to clone something in the mouse, and I had her blood, and in those days, there were no human subject issues, there was no informed consent, so I just put an extra tube in my pocket. And I went upstairs, and I added it to a couple more Petri dishes where I was trying to clone something. And I came back a couple of days later. Ian was still out of town. I came back a couple of days later, and I had positives. And at first, I was disappointed because the positives came from her. They didn't come from the experiment I was doing. And that's how it actually started. And we cloned, it turned out we had cloned PDC. And I stayed for a year and a half, went back to the US, and there were very few people who had any sera that they collected in sera banks. Patients with PBC, people weren't doing it. And I happened to meet, I called a lot of people, and I called not Keith, because Keith was still probably a fellow then. I called his boss, a guy named Raleigh Dixon. And Raleigh was on the phone, and I don't know how much older Raleigh was than I am, but I'm guessing about 20 years.
Yeah, that'd be right.
I got him on the phone, and I explained what I wanted, and he said to me, I almost remember his exact words. He says, listen, he said, I don't understand a damn thing in what you told me, but boy, it sounds important. How many samples do you want? And I said, do you have 15, 20? He says, I got 500 or 1,000. And that's how it started. And Raleigh Dixon and I did some of the early work on AMAs. We probably published 20, 30 papers together. We ended up, developing the AMA test that Innova runs, and it became the platform for how we study PBC. So it was an accident, completely serendipity.
Awesome. What was, give her the microphone. We didn't hear that. Sorry, what was that?
I'd like to correct your statement. I think you are a bit of a medical renegade, and we're grateful to have you.
Yeah, great. Okay, Dr. Vierling, now you.
Well, my story is one of serendipity, too. End of the Vietnam War was unpredictable, although it did occur before I graduated from medical school. You needed, in order to train in that era, for more than 1 year of internship before you were drafted to be a general medical officer. To get 2 years of training consecutively, you had to have a commissioned officer reserve deferment. So I looked at NIH, CDC, these were the places that you could apply. The competition was 100% of all medical students in the US. Eric remembers this well. And it was about 1 in 11 chance that you'd get one of those positions.
Oh, it was less than that. Probably more like 1 in 800 to 1,000.
Well, it may be. I don't know.
I mean, it only took like 80 people a year.
But the bottom line to this is that Tom Chalmers, who ran the NIH Clinical Center, took a liking to me over a question I asked him at breakfast. And because of that, he got me assigned to a new unit that didn't exist. I couldn't apply for it because it didn't exist. It was the new liver unit that he had created at NIH. So Alan Wolkoff and I were the first 2 clinical associates. I show up, and I'm being tutored by the famous and legendary Hans Popper, who had written extensively about PBC. And the clinical attendings I had were Hy Zimmerman and other famous hepatologists. And suddenly I was being educated about a disease that I knew very little about. And I got fascinated about it, and then ended up with Warren Strober saying, I'd like to work with you, Warren, who's in immunology in the National Cancer Institute at the time, because I'd like to understand what these cells are doing that are chewing up the bile ducts in patients with PBC that I see under the microscope. What are those cells? How do they get there? Why do they stay there? What are they actually doing? And that was the genesis of my own interest. So if it hadn't been for that need of a deferment, I may have never ended up in that place.
Great. Dr. Carey, what about you?
Also kind of random. I did my internal medicine residency here at Mayo Clinic, Arizona, and in medical school, I always assumed that I'd do primary care. I guess I just never thought of anything else. And then within a few months of residency in internal medicine, I thought I would not make it as a primary care physician, and so I was desperately looking for ways to specialize. And our program was fairly new, and they were about to start a GI fellowship, so I thought GI sounded great. So I picked a random gastroenterologist and asked if I could do research with him, and it happened to be David Douglas, who started the liver transplant program. And he gave me, it was before the liver transplant program at Arizona started, but he would be evaluating people, and then they would go to Rochester to get transplanted. And he gave me a research project looking at those patients, and just like the more time I spent in their charts, I just became absolutely like mesmerized and fascinated by these people and like the process that they went through. And So that's how I ended up in GI and then transplant hepatology. And then a few years later, Keith Linder made his move from Rochester to Arizona and mentored me, and
Awesome.
the rest is history.
Yeah, awesome. Thanks for that.
There are
You want to give her a microphone? Oh, is it on? Oh, okay.
a few of us longtime members of the organization have heard about Dr. Douglas. For many years, he transplanted a very good number of our early people. And I will just want to say, isn't he the doctor who used to tie the bracelet on you when he finished the transplant? The string bracelet. And they all wore them forever.
Well, he's not a surgeon. He's a hepatologist, so he wouldn't have been in the OR. But you mean like maybe in the clinic?
Yeah, and when they got their transplants, he tied this string bracelet, like friendship bracelet on them, and they all had them, and they were all dirty, and they never took them off.
I'm not aware of that, but I will ask.
Yeah. It's interesting. One of the things for you, Dr. Carey, I think Leslie received a question about mood disorders and how that affects your status or placement on the transplant list.
Candidacy, yeah. I mean, people can have all kinds of psychiatric problems and still be transplant candidates. We just want to know that their psychiatric disease is controllable and controlled. So we have people who have, bipolar disorder, severe depression, substance abuse disorders. But as long as they can work within the medical system, they have some insight into their disease, they're willing and able to take appropriate medication, that does not necessarily exclude them as a transplant candidate. If we get somebody who refuses to talk to a psychiatrist, who refuses to take their medication, somebody who's maybe been in and out of treatment programs their entire lives, those people would not be candidates. But just the presence of a mood disorder by no means would exclude somebody from transplant.
Okay, great. And then, Sabrina, you have another one?
What recommendations do you have for your patients to take care of their mental health, well-being, to maintain a positive quality of life?
Who wants to start? Anyone? Dr. Carey? Or Dr.
We'll go right to left this time.
Okay. Yeah.
Okay.
Me left to right.
Well, it's their right.
Oh, I see. Okay.
Just, it's all things that are probably easier said than done, right? And common sense, trying to keep a work-life balance, or maybe in this case, it's a sickness-life balance, trying to find, maintaining the activities as much as you can, maintain the activities that bring you joy, spending time with people who are important to you, keeping up hobbies as best you can. Eating well is important for all of us, especially in this environment where there are way too many calories and way too many bad calories that are too easily accessible. I think that the mental health is extremely important, and thankfully people talk about that more than they used to. And for some people that just means, maybe going fishing on the weekends and making sure you do that on a regular basis. And some people that might mean having a therapist. So I think it's really just taking the time to know what you need, and then the additional time to give yourself those things that you need.
Dr. Vierling?
Well, I certainly agree with everything that Dr. Carey has said. I think in the time that I've been able to spend with patients before URSO, which was a terrible era, and after URSO and in the continuum, the one thing that I think has been hopefully helpful to patients and families is to try the best to communicate the fact that there are people who care about them, care about the disease, want to see better treatments evolve, and are willing to work in that area to help demystify a lot of misinformation, because I think it lends itself to an unremitting sense of hopelessness or anxiety, and that is unnecessary. I think there is hope, even in those eras where you could maybe find an inkling here and there, but you could emphasize it. So I do think that this is an element that all physicians can provide and truly is an element of care.
Great. Dr. Gershwin.
Well, I take care of patients mostly with lupus, rheumatologic disease, environmental immune injuries, immune deficiency, people with very chronic issues, including PBC and Sjogren's overlaps. And I would just like to echo what you both said, which is that there's no easy answer and there's no quick fix. And it's a mindset that's based on your resources, your family, and where you happen to live. And I don't think society is able to address it. I mean, society is unable to address a lot easier issues than that. So I think it's an individual thing, and I know it's tough.
Great. Thank you for that. Well, I think this has been a good discussion, good wrap up. I know we have a few other questions. Okay, sure. Let's get the microphone up here. Yeah.
Okay.
Okay.
In about 2003,
Let's get the microphone on
am
back
I,
there. You don't have to touch it. She'll just turn it on. Okay? Go ahead, Joan.
okay, in about 2003, I had a local group, and I had in that local group a young lady with Down syndrome who was at stage 4 of PBC. She was declined transplantation because she had Down syndrome. Does that still go on today, or is that still a no-no?
It's a good question. It would, like everything else, be very individual dependent. We would definitely consider somebody with, a circumstance like that with the right situation. I think we would need to know that the patient had enough awareness of what is likely to happen and what they, are going to go through. Obviously, the social support has to be excellent. Those would really be the two primary factors, I think. So it would be a more challenging evaluation. But if you came to me, if a doctor called me and said, hey, I have this patient, I'd say, yeah, bring him for evaluation. Let's see.
Cool. Okay. One last question. It should be on now.
Do semaglutides help improve or support an improvement in liver disease?
Well, semaglutide is sort of the talk of the town, and you know it for two indications. First, it's a GLP-1 agonist, and so it was designed to treat diabetes, usually in combination, and then it's been proven to have its ability to work independently. But more recently, it was approved for weight loss, and that was something that then was extended as an improvement, not just for weight loss and with certain criteria of obesity, but for prevention of cardiovascular disease. So it's kind of the talk of the town, and ads are appearing all over to get your semaglutide equivalent here or online, et cetera. What it has done, and the studies that have been conducted, have been in patients with obesity and type 2 diabetes. It has improved the type 2 diabetes. It's led to a weight loss that is in the range of about 10 to 15%. Some people, it's up to 20%. But the sweet spot's about 15% in a sustained manner. And that has improved their underlying metabolic associated steatohepatitis, the current term for what we used to call NASH. You've probably been more familiar with NASH. So yes, it did a metabolic improvement. So that is the status. It has never been studied, nor is it likely to ever be studied in other diseases, particularly diseases like viral hepatitis, autoimmune hepatitis, PBC or PSC, because the mechanism of action is really relevant only into the metabolic liver diseases.
Okay. Do you think there's any problems with PBC? Any thoughts or?
Well, I think that the issue in terms of PBC as a disease of predominantly adult women, but as I pointed out, in a kind of increasing proportion worldwide of men recognized with the disease, sort of changing the female to male ratio, is that as adults, they're subject to everything that Dr. Carey has been mentioning, and that is a tendency for about a 10-pound to 20-pound weight gain per decade, exposure to kind of an imbalanced diet, and developing the syndromes of metabolic dysfunction, the metabolic syndrome. So we have obesity, we have type 2 diabetes, we have hypertension, increased uric acid as examples of things in that metabolic syndrome. And so that is, when you have obesity and you have diabetes, roughly more than 50% will also have this MASH or NASH. And those two risk factors correlate with that. And I'm always concerned of having two independently active liver diseases, either one of which could move toward a cirrhosis. So I do think it is important. And if one does have a MASH diagnosis, there are things that need to be done, and there is the first ever approval of a drug for MASH just recently. It will be one of probably several, probably leading to ultimately combination therapies that will be more individualized for individual patient characteristics. But I am worried about the coexistence of MASH as an inflammatory process of the liver along with PBC.
Yeah, okay, good point. Well, I think we could probably go on for a few more hours. We have a few more questions, but let's wrap things up now, and you can either stay or just wanted to thank all of you for coming up on the stage, answering some of the easier and more difficult, complex questions. It's been a great discussion. And we do have Dr. Vierling and Dr. Gershwin. Are you going to join us for dinner as well? Okay, she can't join you. But, you know, maybe if you have some other questions, feel free to ask them later. And we also have Dr. Caldy will be joining us later as well as a special guest. So we appreciate all of your feedback, all of your answers. And I think we had a good day discussing a lot of the different topics here. So as a reminder, we do have dinner starting at 6 o'clock. So we're wrapping up now. Feel again free to grab a soda. On your way out, take a little nap. I know I need a nap. I don't know who else needs a nap. But be good to get ready, relax before we get started with dinner this evening. As we get started for this evening, it will kick off at 6, and we have some recognition and awards as well. Tomorrow is going to be even fuller. So make sure you get some rest this evening after dinner. Breakfast again at 7:30. We'll kick off at 9. And we have a lot of interesting topics to cover for this as well, where we're going through some of the mediating impact of stress and well-being. So good lead into that. We're going to talk about some updates about the PBCers organization, fatigue, of course, everybody's hot topic. We're going to be talking about itch later, and also talking about clinical trials. So both from Dr. Patel is going to be talking about that, as well as we'll have a panel discussion on that as well. So hope you all join us for this evening's dinner, the recognition, and thank you all for your participation today. Okay, thank you.
Thank you.